Hello, everyone, the audience with us online and the lovely audience here in the studio. And welcome to Innovation Jam this October 2021. This is just one small part of Halland Tech Week that is going on right now, and it's kind of like a smörgåsbord with delicious talks and very interesting people that you can just get a little pinch of this whole week. And the program continues after this Innovation Jam as well. My name is Rebecca Sellergren, and I'm very happy to welcome you here, and also our guest that I will introduce very, very soon. So this event is a very easygoing event. You can all participate. You in the studio, just shout out if you want to ask something or just say something smart or not that smart. You can choose whatever you like to. And you who are with us through Zoom, you can always use this Q&A formula. Yeah, I think that's the English word. Just to ask questions, but also participate when we are asking you questions, because we're going to do that during this event. So when we ask you questions, answer through the Q&A. Is that all right? You with us? We have a lovely Danish audience here in the studio, just for your information at home. So let's introduce our guests today. Farzaneh Etminani, Assistant Professor in Information Technology and Deputy Project Manager at Kaiser Health. That's quite a title. Yeah, welcome. And we also have Niklas Sundler, Technology Innovation Director at Ramsay Innovation Hub. Thanks. Ramsay Santé Innovation Hub. Welcome. I think we give them an applause. Yeah. So lovely to hear live applause.
Yes.
It's like always been this very sad moment. But now we're back. So I want to start off with letting you give us some of your background information, like what background and why you ended up being where you are right now. Maybe you will start.
Yes, thanks. Hello, everybody. I am working at the moment. I got promoted recently.
Oh, congratulations!
It was a couple of months ago. But I am now working as an associate professor in machine learning at Kaiser Health. But it is at the School of IT, Halmstad University. But I got my PhD in computer science a while ago. It's more than a while ago. It's like, I don't remember, 7, 8 years ago. But then I got interested in healthcare for many reasons. Not only because it was my personal interest, but also it's because of a challenge in the society. So that's why I started to use my knowledge in artificial intelligence, machine learning, to be applied in one of the most important topics, which is healthcare. So then I moved to Halmstad University, and it was my luck probably that I get engaged in healthcare and start to expand and grow in that direction. And now we are standing in a very good, I think, position. Not me, the university I'm talking about. We are collaborating very good partners, big ones, not only in Sweden but in worldwide. So this is a short story of mine.
Yeah, but I was thinking there are many obstacles in the society that needs to be find a solution. What was interesting just about healthcare? Why did you end up there?
I mean, if you look around, at least for me, I have a lot of people around me that are suffering from some chronic diseases, and especially when you go to hospitals or with physicians, you can see, at least I can see that with the help of information and fulfilling some of the lacks that the physicians or healthcare staff are suffering, not because of their missing, it's because of being human, like forgetting, it doesn't have the whole picture over the patient, and those things. I feel that I can do something there with my knowledge and expertise. So yeah, I understand it's not the only promising area of research, but this is my personal interest as well as I mentioned, it's a societal challenge. Especially during the pandemic, we saw that the use of AI can do something in many areas, which we are going to talk about it more.
Yeah. Yes, we're going to talk about a lot of AI today. But first, Niklas, You're going to talk about your journey. What brought you from your, not since you were born, that would be a very long story, but why are you here today?
We are here from, I'm working at Ramsay Santé, who also owns Capio, which is the Swedish brand of it. I'm working at the Innovation Hub, and at the Innovation Hub I have a role as a Technology Innovation Director, which will mean that I work with a lot of the innovation regarding technology. And one of those initiatives that we are running is together with the Kaiser project. As a part of that. If you go back to the background, I've been working with the Innovation Hub for 2 years. Before that, I've been working both at Telia Healthcare, starting up that, working at Region of Skåne as an IT director and so on. So I would say the last 10 or 15 years I've been working very much within the tech area, within the healthcare setup.
And was that like, I ask you the same question, that healthcare was like, yes, this is really what I'm going to do. How did you end up in that area?
I would say that I actually started on the IT track, and I was kind of the black sheep in the family, and the rest of my family is doctors and nurses and so on. Then after a couple of years I had the opportunity to start at Region of Skåne, and then kind of combining the two worlds. But of course, I mean, the reason for working with healthcare is that you really feel that you can do a difference. I mean, it was the same when I was working at the ICA as a retailer with IT solutions, that you could really feel the pulse when something was not working and when it was working. And on this side, it feels more even better when you have something working.
And is it common that caretakers do have innovation hubs like Capio and Ramsay Santé?
I think it's more and more common today. A couple of years ago, I was saying no, not in the same way. But I mean, due to that, you are now introducing more and more digital service and more digital support in different ways. It also comes more and more natural that you need to understand more around what is happening in not just right now, but also where should we end up in the future.
And as I was saying before, this is Innovation Jam, and Jam comes from participating as an audience. So now I'm going to ask you a question, the ones who are sitting in the studio, but also you at home. And that question is, what relation do you have to information-driven care? And this doesn't have to be hard. You can work with it. Either you can be a patient who have just ended up heard something about information-driven care, or it could be something that you read in the news. So take like 2 minutes, you talk to each other here in the studio, and you at home, you think about it. What relation do you have to information-driven care? And then answer in the Q&A formula. Yeah, formula. Thank you. And you just answer in the Q&A. So take 2 minutes. What relation do you have to information-driven care? Go. Okay. Thank you. This is what I really like about the jams. Everyone is chattering with each other. Do we have any comments in the studio? Yeah.
Yeah. Hi.
Hi.
My name is Peter, and I work at an innovation unit in Denmark. And at the moment, we're looking into the possibilities of working together with a small company working within AI, together with the acute department. One of their big problems is that the nurses there, they need to know 6 weeks in advance when they should work, which is fair enough. But the problem is, can we predict how many nurses we need to man the acute department with 6 weeks in advance? So the idea was to actually look, of course, historical data, and also actually just looking at season and festivals and all sorts of other public data, and then actually say, can we predict how many nurses should be at the acute department at any given time? So we're looking. It's a project that's been done in the north of Denmark, and we're trying to find out would this make sense within our unit as well.
Yeah. Nice. Do you have any comment to that?
It's pretty simple. It's very basic, yeah. But it's something that they actually need, and they spend a lot of time manning, just trying to find out when they should be there.
And I think that actually I worked a little more with that kind of question at ICA on a retailer point of view and fulfillment point of view. But the kind of question is I mean, solving, especially now when we see that we have and will have a more lack of resources in the healthcare, it will be even more interesting to understand how could we optimize, how could we work with the staff that we have, and which kind of way would you use to actually make sure that you have the right kind of competencies in place. And it goes also back to the technology point of view, which kind of technology, which kind of work do we need to do with which certain level of competence to do that, and how can you combine that in the best mix. So I think actually maybe you should add that dimension to it also. Could you actually work with the mix of competencies in that dimension also?
Yeah, and actually
not
saying,
just
should we man them
resources
with nurses, or should we have this kind of doctor or that kind of doctor?
Yeah, precisely.
Yeah, interesting.
You should get together afterwards. I really like the sound of this. And we also got some comments from Zoom. Thank you all. Zoom, you could reach out to us through Q&A. And Erik, he's writing lack of interoperability. Yeah, you know that word. That's great for you. How can we improve this area? But it has improved in the last years. The Swedish pharmacies are much better now, for example. And Omar, he's saying personal interest, and I'm working in research domain on topics related to healthcare. Thank you guys at home. And we continue talk about AI and information-driven care through Kaiser Health. And Farzaneh, I thought that you would tell us, what is Kaiser Health?
Yeah, Kaiser Health, first it stands for Center for, I forgot, Applied Intelligence System Research. Sorry, I always use the slides, so now I need to. And so it is Applied Intelligence System Research in health. So then it's Kaiser Health. If I want to define it, it's a research profile. So it's not a small project. It's it's an 8-year program that is funded by KK. And it's a collaboration between academia, which is Halmstad University, and 7 to 8, if I'm not mistaken, industry partners, big ones, really big ones. So Capio is one of them, and we have Cambio, Visiba Care, then we have Mölnlycke, Novartis, Halland, if I'm not mistaken.
Solution.
No, InterSystems.
InterSystems.
Yeah, InterSystems. We have that, but in another context. And of course, we have Mass Brigham Hospital also on board from US. And our public partner is Region Halland. So this is a collaboration between industries, academia, and public sector, which is Region Halland. The main vision, as you mentioned, is information-driven care. So we try to to study different AI machine learning techniques if we want to implement it in real practice. What are the challenges? So it's not just working on very nice AI algorithms that will stand in libraries and journal articles. We are interested to also implement them in practice and solve the adoption of AI solutions. Because nowadays people are really keen to see how AI can improve their routine in healthcare. How can we really see the impact of AI in the healthcare routine? The example that you brought up was a very good example of resource management, which we call it as a low-hanging fruit, because having that information, you just need to build some models on top of it and use it. So it's not that big deal to really implement it in practice. It's not that much that affect their care routine. But in the second stage, we are interested in Kaiser Health to study the use of clinical decision support systems in practice. That is what, to save the time of the physicians and nurses and midwives, whoever is talking to patients, to talk to patients and not on the administrative work. This is the first low-hanging fruit that we are aiming for. As I mentioned, it's an 8-year program. We recently started after summer. What else should I say? we have a couple of projects up and running at the moment. We have 4 projects, which all are around proactive care. We try to intervene before it happens.
Okay.
We try to work on that. We call it proactive care. It's not preventive that way, because if the person is already sick, we cannot do anything to make it better, but we can prognose something to intervene before it happens. So it's a kind of proactive care rather than reactive. So the main topics of the Kaiser Health were around the different healthcare system characteristics that is at the moment, like being reactive, being more centralized in healthcare centers, and like being more working on average people, not including that much patients in the loop. But we try to overcome or touch upon those ideas of being more proactive, being more personalized, care around the patient's needs and status, and also working on the care democratization to avoid doing everything in one place, to include patients and empower them. So I talked a lot about different things, but I hope that we can have different projects around it.
Yeah. And we should zoom in on some of those 4 projects. But first, Niklas, you will tell us, why was it important for Capio to be a part of Kaiser Health?
I mean, we are Ramsay Santé is the second biggest private healthcare provider in Europe. In Sweden, as Capio, we are the biggest one on the private side, mainly on the primary care part, and with that as a background, I would say that we have a lot of patients that we have contact with today, and what we see is that now it's coming more and more digital service. It's coming a different dialogue with the patient. They have adapted more and more to the mobile phone and the way of actually having that as a part of the daily life. And going back to that, I think that and as we said or pointed out before, the amount of staff that will be available within the healthcare sector over the next couple of years, we need to get more digital support, and in that point of view also capturing and supporting people much earlier than we can do today. So from that point of view, it's really natural for us to be involved in this kind of projects, because it will give us the opportunity. I mean, we have activities within prevention, we have activity within early finding or understanding very early how we could capture the patient that are starting to get sick. And then of course we'll need to look into the processes and activity when you are sick. How can we optimize that? How can we support that in a broader point of view? So we have different initiatives, and this is one that is very important for us.
And I just want to remind you all here today that you can answer question whenever you want, and as well you at home. Just use the Q&A formula. Thank you. And now let's zoom in on some other project. You can choose whatever you want. What are you doing in Kaiser Health? Which project do you like the most, Farzaneh?
That's better not to.
Or just pick any.
But we don't have that many projects because we just started
This August.
Yeah, this August. So we started with 4 projects, which I can talk about 2 of them more here. One of the projects, which is with, together with Capio, it's around anxiety, depression, working on early prediction of people who are kind of dealing with anxiety, depression in young adults. Especially during the pandemic, it was a kind of a problem with people between 20 to 29 that are suffering from anxiety, depression without knowing that, because it's not when it comes to mental illnesses, it's not as obvious as physical ones, that you suffer from a pain and then you go to doctor. It's not like that. And anxiety, depression was selected to move forward. So it's not just, and again, I'm saying that it's not just we try to early predict them and then we want to understand the whole journey. When a person, as a young like me, I'm not 20 to 29, but I'm thinking about a person who is young, they think that they are suffering from some anxiety, depression disorder, what they are doing. So just to understand the journey, the patient journey, starting from looking into some apps, some internet forums, and even going to hospital for some chest pain or heart pain, or these things that are not the symptom for mental illness in the beginning, but it will develop. So we try to find those early things, indicators, and then use them some way in the care routine to flag the people. So we start to understand both from patient side and from we don't call them patient, they are just seekers, health care seekers. And then from the healthcare system side, how can we really improve that before the person get into the very last stage of harsh treatments and psychiatric treatments? Yes.
How do you, sorry, I don't know if you can.
Yeah.
How do you identify that data? How do you find it? Because you can't just do a Facebook search for people looking about something about anxiety or going on Instagram or whatever. How do you what kind of data do you use actually?
That's a very good question and concerns some ethical also aspects. So we start step by step. We decided to start with first healthcare records that are collected at the moment, and we know who has been ended up with having some diagnosis around anxiety, depression without having it before. So we start to learn something from that, and then start to enrich the data sources based on how much we can go really further. As you mentioned, that the last stage would be Facebook, Instagram, and more personal information. But before that, some of the people are really willing to participate in those studies. So we start with student health centers that are mainly in the universities, because it seems that students, which are young adults, they first go to that centers and not directly to the healthcare. So we start to understand what journeys really these people choose, and then try to intervene at the right time. We don't really know when and how to intervene. This is part of the project to learn. So Capio, I think you have a lot to say.
Yeah. I mean, and as you say, I mean, the thing is to try to find what could we do and what could we not. I mean, one thing is, of course, what should be the optimal formula and which kind of data could we have as the best case to understand and describe the scenario. But from an ethical point of view, you will not go the whole way. So in that point of view, you need to understand, you have both the ethical point of view, you have the legal point of view, and of course you as a person, you need to feel comfortable with what is happening. So with that as a background, we need to understand which kind of sources could we work with and how could we actually combine them to get the kind of results. I mean, and I also would say that we have several sources that could be of interest in this case, and then we need to figure out are they relevant or not, and in which way could we use them to do this. I would say that we will come back with the answer in a couple of years, and when we have a solution in place.
Yeah. I think we have a question. Yeah.
Hi. I was also thinking about the users and kind of like the end product. Is it that I'm as a citizen going to my medical doctor and then he says, Magnus, I can see that you've been doing some stuff. Are you okay? And then I could imagine that I would feel sort of watched upon and that he would know a lot more about me than I actually wanted him to know, perhaps. Is there a...
And that is why I also said that you need to feel, as a patient or a person, you need to feel comfortable with what we're doing, because otherwise you will not come to us. Then you will come to someone else instead. If you don't feel comfortable, what will happen? But I mean, the way for us to capture it, I mean, it could be that you're pointing out that we'll have a dialogue directly with you from a system or from a digital service, but it could also be that we actually, in the dialogue, when you are meeting a doctor or whatever, we could feed that a physician, or we could feed that with the information regarding that. Now we can see these symptoms in the dialogue. Please look into this area a little more with this patient, because it could be that it is a potential to actually take some further in that area or doing that kind of thing. So that is also a way. And then you go over to the next step would be that we actually, with the looking at the population, could look at this could be risk groups. I mean, you know from a point of view when you see the diabetics or whatever, that if you're living on this certain distance from fast food places, you don't have any things to do activity in that area and certain and so on, you can actually start to predict which one are in the risk group. And so that is also something to look into. How could we work with that? Because that is nothing that we work with today in that point of view. So I think it's an interesting way, and with the project and these kind of things, to understand that this is one route, but it could be several routes around, and actually seeing how this will end up as a solution, I think, both from a medical point of view and from an individual and patient point of view.
Is there any other project that you want to bring up within the Kaiser Health?
The other project, which it started with the same time with this mental project, is it's about focused on heart failure patients. And you know, heart failure is a kind of a disease that I don't want to talk about the medical aspects, but the problem is that these patients will unfortunately get hospitalized quite often, and with different comorbidities that they are suffering from. And at the time of discharge, it's a very important decision by the doctor to be made if the person is going to be in need of care, but being discharged sooner than needed. Usually these decisions are made in a committee between different doctors, and they don't have a consensus sometimes. So we try to intervene there and help with some prediction algorithms, how probable that person gonna be readmitted within a time window like 30 days. And not only mentioning how probable, but also opening the black box, opening the prediction algorithm to show why that person, for example, is 90% probable to be readmitted within 30 days. So it's not just a prediction algorithm, but we also want to touch upon what we call it explainable AI, to open the black box for the decision makers to make the decision more, because if I was a physician and the algorithm told me, okay, 90%, but why? Why should I, for example, keep the patient in the hospital? Or what the decisions should I make? If I want to discharge it, should I send a nurse home or call them? So the decisions afterwards would really rely on what are the reasons behind that 90% probability. So we want to study that as well. So we call it readmission prediction algorithm, that we try to implement it in a clinical setting in region Halland and some other control groups to study what will be or how much we will really benefit from it, and what are the challenges if we want to implement it in practice for like heart failure patients who are going to be discharged.
So you have tried it.
The algorithm in theory it works really well, but then we want to study it in practice.
Okay.
That's the question. Okay, what are the challenges? What interventions can be of the most benefit for beneficiary for the patients and the doctors, more depending on regions, depending on the situation of the patient. So these are questions, research questions that researchers are working on it.
And already now maybe you got some expectation from the doctors. What do they say? Do they like this kind of algorithm telling them?
That's we're working on it.
Okay.
But generally, as I mentioned in my first opening, user adoption is something that we should work on it, and the barriers or the steps to you really work on it is not just that they adopt it by pushing them to adopt it, but we should work on the reasons behind that, not being adopted. Because the main reason we realize that one of the main reasons is that the design is not nice enough. So we should work on the design, we should work on the performance, and we should work on the transparency. So these are the three main key factors that we try to touch and find the solution. For design, this is the human in the loop, human-centered design. These are the nice terms that we hear, but we really want to do that. In the performance, of course, it's our job. I'm a kind of data scientist in some sense. So this is we really work on state-of-the-art algorithms to make sure that what we are saying is really not better at the moment. We cannot find a better accurate model, for example. And when it comes to transparency, it's very important now to, as I mentioned, opening the black box or designing a white box from the beginning to help building this trust between the users and the system. Users can be physicians, but also can be patients. Patients may be reluctant, as you mentioned, to open the data really send the data from their homes or sensors to the hospital. For different reasons, they might not be interested in that because they might be thinking that we are under control or somebody is watching me. So these are the things that we need to work, and it's not me and you, but the whole AI in health research.
And we will come to AI in society later on, but you were humming with, we want to add something to
Yes, I
Farzaneh.
mean, just pointing out, as you're pointing out, I mean, the change from a doctor's point of view and the healthcare system, I mean, it's a pretty big change that you are in the middle of right now. I mean, the first adoption in kind of just having a video meeting instead of a physical meeting, and the process and dialogues that have been going on for a while regarding that and the benefits and now going over to a more data-driven or data-supported scenario to support the doctors and the nurses with what is happening from and what we could find in the data setup. I think it will take some while and it will be a process, but we need to take it stepwise and have it up. And then going back to the ethical point of view, meaning and also showing why are we going to this result. And I also think that going back to the dialogue from an EU point of view and the regulation dialogues and so on, that it's up for dialogue right now. I think it's important that we actually can explain why we gave a certain recommendation, why we came to a certain kind of point in those kind of dialogues also.
We have a question from our Zoom audience. What is the difference between a black and a white box? I really
the color?
don't know the color.
You didn't know? But yeah. The black box, at the moment, AI looks like a black box. Even a data scientist cannot really explain how it works because it's like several mathematical models in between that they are just multiplying and different mathematical operations. And in the end, okay, 90%. I cannot really explain how it works. Even a person who knows the artificial neural networks, for example, cannot really explain how it works. So for those models, they are black box. They cannot be really opened. So we try to attach or do post hoc processing to find explanations. But white box, if I want to give you an example, if you have ever done the troubleshooting on Windows, for example, it asks you some questions and step by step goes you to the end, some decision. It's a tree model. Those tree models are white box models because you don't need explanation, you just show it and everybody understands it. So by nature, they are white box. So they are, the reasoning is human interpretable and understandable. It doesn't need something to be added or post hoc or in-model explanations. But black box, the problem is that black box model are the most accurate ones. So we are dealing with two dimensions, explainability and accuracy of performance. They are not walking in the same direction. The more complex, the more accurate. The more explainable, unfortunately, not that accurate that we wish for. So you should deal with something. That's why we cannot really put aside the black box model. What we do is that we try to open it, to explain it. By, for example, if I want, a very nice example is natural images. If you have seen these very nice models that can predict if this, for example, if the image contains a cat or a dog or a tree, they are very nice and 99% they are accurate. But why, which part of the image corresponds to, we try to highlight that part of the image that corresponds to that cat and dog. And then you, as a human, you can see, okay, that makes sense. Or no, it's just a background that it decided that it's a fish because it's mostly water. So we try to realize that because it has been sometimes that the background, for example, was important more than the features in the... this is what we try to do with the black box models.
Nice. Good explanation, I think. Yeah. So we should soon move on to ask you another question, the audience with us at Zoom and here in the room. But first, what does it mean for Kaiser Health to be a collaboration between the university and business and like the public, like Region Halland? What does it mean to have all these?
Yeah, when it comes to healthcare, these three are very important and complementary because I start with region, with healthcare provider, the main like public healthcare provider. They are the main kind of users. Both patients will go there and doctors are sitting there. So they are the main users. Even the healthcare industries, they are Capio, I don't see. I think they are not a healthcare industry. You are also a healthcare provider, but in a private sector. But the other industries that we have, they are also directly work with regions and patients, not with the university. So we are in the middle, and we try to really work on, as I mentioned, to touch the state-of-the-art research and improve and strengthen both the region, which means the healthcare provider, and the industries, to strengthen them because they are the people that I am a human beside being a researcher. Yeah, okay, really? I've tried to prove it, but. It means that I need to be there. It's not something that I do it for others that they use it. It's I'm doing it for myself as well. So it's a very important societal thing that we are touching upon. That's why these three main actors are really complementary, and even our partners are complementary.
But I also think that, I mean, from a university point of view, if you don't have the dialogue with the user side, if you are like just doing from a university or from a high school point of view doing the research, then it's a risk that the research be more on a theoretical point of view,
Abstract,
and not so connected to the actually value. And the same way if you go to the commercial side and you just look at from a commercial point of view, the dialogue would be different, just going down to what are they willing to pay for. And in this kind of dialogue, where we actually could have the 3 dimension, I mean, from a consumer point of view, a producer point of view, and from a researcher point of view, and we could combine that into a dialogue and create some kind of open table or open box and actually contribute in different ways. You have a completely different kind of dialogue. That's my experience. If we would like to go out as a healthcare provider, go out and buy something, then we will have a certain kind of dialogue. But by involving the researcher part of it and university point of view, then we get a completely different kind of dimension and level of the dialogue that we have.
So now, after hearing Niklas and Farzaneh talk about the information-driven care, you are going to talk about what opportunities you see with information-driven care. Maybe you come up with some great ideas sitting here, I don't know. But what opportunities do you see with information-driven care? You in the room talk to each other, and you home at Zoom, you think by yourself, or maybe with someone at home or at your office, and then comment in the Q&A. So we'll take like 1.5 minutes. You go. That's about 1.5 minutes. Sometimes I call it theater minutes. Then it could be how long, how short you want to. So do we have any thoughts from the audience here? What opportunities? Yes. Was it Magnus?
Yeah,
Yeah.
Magnus, yeah. I was thinking about instead of treating symptoms and then start preventing it from even occurring. I think there's a huge opportunity there, and as we also saw in the previous presentation from Leap, there's a huge it's so expensive when people get into the hospital,
Yeah.
and then they get home, and then they get into the hospital a few days later. But if we could, as a society, look into how we could prevent diseases before they even occurring, instead of treating the symptoms.
What do you say about that?
Yeah, I think you define the reactive versus proactive. Exactly, that's the definition of it. So, as you mentioned, the healthcare systems are a kind of reactive. They wait until we get sick, and then they intervene when we go there and visit them. But as you say, it's what we wish is to find the indicators that corresponds to some sort of diseases and act before it happens, like a flag or an alarm or something, a trigger that either directly to patients or when you are with a doctor, then they can say, okay, this person is 50% chance to develop blah, blah, blah. And then the doctor can decide. Again, you can see that we are thinking about augmenting and helping the physicians, not replacing them. That's very good that nobody has mentioned it. I'm really happy.
Some other thoughts from the audience? No, then we have a question from the Zoom audience. What do you think is going to be the best practice in 10 years in healthcare? Are we going to use AI in broader perspective than today? In that case, how? You're welcome.
No, but yes, I think we will have more of it into the healthcare system. I also think that, as we just talked around, the moving over from being a reactive to be a proactive point of view, in the way of using the data, and in that point of view, trying to capture, support the individual in a much better way than we do today. I mean, the way that the system that we have today, I mean, we can't go on that way. We need to go over to the preventive things, or capturing it much earlier.
Do you want to add something, Farzaneh?
Yeah, I think scaling the AI in healthcare has different levels. The first and the most, or kind of low-hanging fruit, is using it in imaging, which is the most sensible now, like in radiology, in pathology, in those areas which is more, AI can show its impact the most at the moment. But then if we go further with more chronic diseases like oncology, cancer, and then neurology, and those areas that still have some images in the loop, but the chronic aspect AI can be used. And you see that the care is, at the moment, is more episodic. We go and then go back home, we are on ourselves, and then until the next time. So to work it as a continuous, to connect these two episodes together, AI can work on that in the second stage. And then the last, which is the best and ideal, is to use it as a routine, as I mentioned, to have AI as an integral part of the care routine. So doctors use it as a support that, as I mentioned, if they tend to forget, they don't have the whole picture of the patient. They have to start to read from 10 years ago about that patient, what has happened. If we can show it somehow to the physician to help them to decide for the patient, not on behalf of them, as just a clinical decision support system, that would be the last for now, I think. I see.
Also to add on that last part, I think that in some way we need to find a way of having it between the contact of the doctor. So it will be, as you are adding on some kind of a seamless part, or meaning that you will, sometimes there will be a doctor involved in it, but sometimes you will be more on your own, but at the same time have the support and building the continuity, or the continued part of it. We need to solve that in some way within the healthcare system.
I think we got another question.
Yeah, I think there's a big potential, but also a challenge in the healthcare professionals to understand and to read the data and how they should understand it, the doctors and other healthcare professionals, and do they trust the black box, the algorithms that you don't understand, that even you don't understand?
Yep.
How can we fix that?
Yeah, these are the challenges when it comes to AI. AI solutions in health, not only in health, in other sectors also, they are suffering. But if you go to a stock market, that's a different story from healthcare. You here deal with lives and the health. So it's not just, of course, money is also somehow related to, but it's not that big deal compared to health. So we don't accept any error. We don't like it. So these are the challenges that open the research area for researchers also to work on the transparency. Transparency is very important. Some people call it even trustworthy AI. So the AI should be trustworthy. And how, these are the questions, how to, as I mentioned, open the black box, add some explanations to make it more clear behind the reasons behind that decision. The design is also important. The performance is important. Who really provides that data for that? Not everything is collected in the healthcare system. There are a lot that I collect through my smart sensors, smartwatches at home. Who should collect that and how? So these are the questions that we are working on it as, again, AI in health research.
Yeah. And I also think that, probably, you can't expect as an individual that it will only be a doctor or a healthcare system that is actually acting on the data that you deliver in the whole time, because that we will not have the capacity of doing within the system. So in that point of view, it needs to come back to that you as an individual in some way, you will have your data and you can actually choose which kind of digital service or which kind of support you want to have over time, because that will change. In the same as you have different kind of specialists, you have different kind of doctors, you are choosing different kind of banks for your different digital service and so on. And that will happen also when you come back to your health and the support from that point of view. And then in that way, then it ends up in that you as an individual, you must have control over your data set and your data to be able to use it in different kind of services.
We got another question. Great with questions. Good. Love it.
I was also thinking of an ethical questions. You just been into it, but like when Tesla announced their automatic driving, if they ran someone over, who was the responsible? Was it Tesla's algorithm or was it actually the driver? Could that be a potential problem with medical doctors as well, that they have an algorithm or AI that says there's a 90% chance that you should do this, but I as a medical doctor choose not to do it. Yeah. And then something happens that I should have followed the AI.
But I think it also goes back to the kind of measurement that we have today. You have an what's it called in English? EKG, EQ. You're looking at your heart rate. You're looking at your taking different kind of medical device a different kind of way that you work on with the hospital to support the doctor. And I think in that way you could compare it with, the algorithm and the setup. Of course it needs to be treated in the same way as a medical device in that point of view. And as a doctor you need to respond to it in that kind of way also. But the same when you are a producer of it and you produce the device or the algorithm, and then you have a responsibility for actually what it does and which kind of result it gives. And that, I think it will grow, and I think that also is a part of the EU dialogue and regulation that is up for grab and out for comments right now. It also goes back to that it needs to be a responsibility around it. And when you use it, you need to be able to explain why you've been using it. And also from an ethical point of view, what is the result of it? Is it just tested out and based on data from young men, or is it actually an accurate amount of data that you've been working on it and in a scenario and situation of it also?
Great questions. Do you have a question as well? Maybe,
or a comment or whatever. Yeah, because I've been thinking using the AI as a prognostic tool as well, in the way that we're working at the moment with a neurological unit in my region, and after you've hit your head or you've had a brain damage, you start to rehabilitate. And of course, a lot of the interventions they use there are based on research, but a lot of it is also, this normally works, this might be a good idea, and this works on most of the people that we do it to, but actually trying to gather data that can actually tell you, well, on this person, this kind of intervention would be beneficial. So the next question is, of course, how do you gather that kind of data? We're trying to find that out. But actually trying to find out what kinds of interventions are the most effective on the individual.
And I think that is something we will work with in all of the scenarios forward, trying to understand which are the scenarios, which are the data sets, which are the way to process them, and how, and in which way should we actually act on the different kind of results of it.
And time is about to run out, but as we are talking about a lot about data right now, it's information-driven care, so why wouldn't we? And I've been hearing about AI since I first came to Leap many years ago, it feels like. But where do we stand on the ownership of the data? We've been talking about it a little bit. Is it hard to get all this data? Where do we stand? Where do you think we're going to evolve this question in a couple of years? You understand that question?
Yeah. Yeah. Maybe.
You start?
Yeah.
Or should I start?
We decided you start.
Oh, you get rehearsed? No.
No, it just. I can start a little bit. The situation at the moment differs from country to country, and in some countries, region or states to states. But so the situation at the moment is different from what it should be probably when it comes to future. So it is of question who owns the data. Is it am I the patient who is owning the data because it's about me, or is it the system that is collecting that, like the regions, healthcare systems that are collecting it? So it's is it the company that providing the smartwatch? Is it that company that's collecting the data? It's again about me. So it's a lot of ethical questions around it. But at the moment, it's different. At the moment, at least in Sweden, as far as I know, the regions owns the healthcare data that are collected in their systems. This is how it works at the moment. But whatever it's collected around myself at home, it's owned by myself. So I can see it myself. But the companies can use it, of course, for as long as they don't use it as an individual level, as overall patient or group level, that's to improve their system. It's the same with healthcare data. If you're working on the group level to improve some group population health, that's not a problem. But if you drill down to individual level, then story is different. And medical device regulations come into their place. Who owns the data? How we should treat that decisions.
I think it's also important, as you're kind of pointing out, that to understand that at the data that is created within the healthcare system, that is just a teeny piece of all of the data. The data that you are providing with I mean, the phone who's tracking how you're moving, this watch, this one, and so on. I mean, and all of them is building different data set, and to actually take the next step, and then you need to combine this data, and then it goes back to you as an individual. I mean, you can't really expect. You need to be aware of that, and you need to take a responsibility, kind of, in the way of actually making sure that you are storing and keeping the data and understanding where you have it, because it will be that data that will be able to describe your life later on, because there's no one else that is taking that responsibility, kind of. Yes, from a documentation point of view in a medical scenario, or from a watch vendor or device vendor, they are of course building it, the data, but you need to understand which kind of data you create and how you would like to use it in the future.
And this will be our last words here at the Innovation, because the clock has taken up to 1 o'clock, and I want to thank you so much, Farzaneh and Niklas, for coming to Innovation Jam. Give them a big applause.
Thank
You too at home. It's very mysterious. We got an anonymous attendee. You can read the comment later on because now the time is over, and Innovation Jam will be back the first Thursday in November as usual. And thank you, our gorgeous Danish audience, and also thank you at home who have been watching us through Zoom. So now Halland Tech Week continues, and as I said, Innovation Jam is back in November.
Thanks.
you.